Let's go. Hello and welcome on behalf of the GC Orthodontics team. Thank you so much to all of you for being here and spend time with us in our webinar today. More than 300 registrations all over Europe. Thank you so much. The topic is CCO and the transverse dimension. Diagnosis on a regular basis, vertical and sagittal. But today we speak about the importance of the transverse for a patient-oriented and perfect result. The transverse is a pillar of the CCO system. It stands for Complete Clinical Orthodontics. Dear Julia, muchas gracias for following our invitation. Thank you so much for sharing your experience and expertise as well as your passion in orthodontics with us. Thank you so much.
Thank
Before
you for having me.
I forward, um, please, we will be happy to answer all your questions. Please put it in the chat. And so, Julia, the stage is yours. See you later.
Sure. Thank you, Brigitte, and thank you for having me. It's always a pleasure to be with all of you trying to serve what we do. So before starting, over here, I will just talk about me 2 seconds just for you guys to know where I'm from and where I was trained. And actually, I am from Madrid, from Spain. I studied and I did my dental school over there. This is my city, but after doing my dental school and after working for some years in Spain, I decided to be trained as an orthodontist in the US. So I went to Philadelphia, the city of brothers in love, and actually I went to UPenn, University of Pennsylvania. This is like a picture of it. It's like you guys watching the movies, the same with the fraternities and everything like that. And I was able to study in the first dental school of the US. And actually, it was the same place where Edward Angle, who is the father of modern orthodontics, I'm sure all of you know who is him, studied also. So I always put this picture. This was the old part of the dental school, and actually these are like the new parts, no? And also this is the main clinic actually from there. These were my classmates at that point. We were 7 each year doing the ortho program, and then we finished doing the masters, 2 of us. And this guy over here on your left side is Dr. Van Arsdal, and on your right hand side is Dr. Amsterdam. Dr. Van Arsdal was the chairman of the orthodontic program at the University of Pennsylvania for 25 years. Before being an orthodontist, he was a periodontist. And it was amazing because this other guy on the right-hand side, who was a periodontist, he told him, please, we need you to do orthodontics just to help us with the gum, with the perio. And this is what he did, actually. They were seeing that many problems that the perio people were having, they were being able to be solved with ortho. And the orthodontists helped a lot the periodontal tissues. This is Dr. Van Arsdal, and thanks to him, today we are talking about the transverse dimension. Also, this is my office in Madrid right now, and here is where I practice orthodontics with my brother. And my brother is, he does all the part of aesthetic dentistry, so we work together in many cases. So today, what we are going to talk about is about this, is about transverse, about the CCO system. This is the system that I use, Complete Clinical Orthodontics, but of course there is no system without diagnosis. And it's not only about the vertical, it's not only about the sagittal, with of course, they are important, both of them, but they are as important as the transverse because it's also another dimension. This guy, and I'm not going to be tired of mentioning him. It's not that I'm going to mention him many other times, but it's very important for you guys to know him because he was the one that that understood the transverse dimension very well and understood and actually taught us how to diagnose it to be able to prevent periodontal problems. I want to show you guys this picture, this photo. Please check it correctly. Look this side, look the recessions. This is a patient that came to us last year, 32 years old. She had ortho treatment when she was 13 years old. Look at the periodontal tissue. It's thick. Look at the recessions. What happened here? What happened? This is not only her. I mean, I'm seeing this in many cases, not only in this transverse dimension. I'm also seeing it in this dimension. We are pushing the limit. We are pushing the limit. And as I'm telling you, we are pushing the bone. We are pushing the corticals. And I'm sorry, guys, to tell you, and maybe some people don't want to listen to it, but there are limits. But there are limits. And when we cross those limits, we have these issues. This patient came to my office telling me, no, my period dentist is sending me here just to see if you can give some torque to the roots inside, and then he can graft. Well, you know what, lady? I'm not able to do anything here. I'm so sorry. So these are things that we are seeing nowadays. I remember still when we were using like the Damon system, that people were complaining because with the arch wires they were being able to feed all the teeth inside without a problem or whatever, and they didn't need extractions anymore. Very good, and we were seeing this. But you know what? With the Damon system, at least there was a limit. The arch wire, of course, the arch wire was super huge, but at least there was a limit. But you know what I'm seeing now in the liners? You know what I'm seeing now in the clean checks? When I receive a clean check, because I do aligners like everybody else right now, like every orthodontist right now, and they are good and they work. But when I receive the clean check, when I see what the technician did, the first thing I see is dental expansion. Dental expansion. And as much as they need to align all the teeth, and what about these limits? What about the bone limits? So this is what we are going to talk today, and I hope at least I'm able to show you guys when the maxilla is narrow. I mean, when there is a transverse discrepancy. Remember that the upper jaw and the lower jaw have to be coordinated. I will tell you how is that coordination how that coordination needs to be, okay? And I will try to show you at least how to see that there is a transverse discrepancy. Before that, I would love to talk just a tiny bit about the CCO system, okay, and what we use. Of course, without diagnosis, there is no system. First things first diagnosis, then treatment plan, then mechanics. But everything is important, because I don't care how good you are moving teeth if your diagnosis is not correct. And I don't care that your diagnosis is amazingly good if you don't know how to move teeth. So everything is important here in orthodontics, okay? So just talk to you a little bit, what is this thing of the CCO? CCO is a system that is called Complete Clinical Orthodontics. It's not new, and what we did is to put together the best of everybody. Take the best of everybody that was before us and put it together with what else? With a straight wire appliance, active self-ligation brackets, and nowadays technology. And when I talk about nowadays technology, we are talking, of course, about CVCTs. This is not the future anymore. CVCTs are not the future anymore. All these cats, we need to see them. We need to be able to measure them. We need to be able to understand them. Actually, the other day I was talking to a friend, and we were saying, you know what? I don't care how digital is your office if you don't know how to use those digital things. And of course, you need to understand how a CVCT works and how to read it. you need to know how to scan, and you need to know the limits of the scan. If you are printing aligners, you need to understand how it prints, or the software that you are using. You need to understand digital. You need to understand the technologies that we have today. Of course, also, look, we are going to talk about these expanders, these bone expanders that right now, everybody's talking about the bone expanders, the MARPs and all these. We would talk about them also. Also about, you need to know these new technologies and how to diagnose the TMJs and everything, okay? And even with the corticotomies, new techniques, new systems, and this is always important to understand. So this is what the CCO is. CCO is an efficient, reproducible, and a consistent system that delivers quality. And this last word for me is the most important one, delivers quality. Because I don't care how efficient or how reproducible is this system if the results are not good. This is important. And when I talk about that the results are not good, I'm not talking about a class 1 canine. I'm talking also about the health of a mouth. This is what I'm talking about. Okay. So regardless of where you start, I want a system that the end is always the same. I want consistency. So for example, like cases like this is a class 1, deep bite, nothing crazy. First wires, last wires, case finish. Cases like this one that we have an ectopic canine, retrocline incisors, class 1, nothing crazy. First wires, last wires, case finished. Class 3 over here, lower extractions, first wires, last wires, case finished. Class 1 with severe crowding, 4 extractions, first wire, last wire, case done. Open bite, 4 extractions, first wires, last wires, case finish. Surgical case, first wires, last wires after the surgery, of course. This is not magic. This is diagnosed and then mechanics, and with the orthodontic surgery, last wires and case done and finished. So this is why I wanted to show you cases that they were open bites, surgicals, with extractions, 4 extractions, with 2 extractions in the lower arch. I mean, I wanted to show you some cases because what I want in this system is that regardless of where you start, the end is the same. Consistency, okay? So this is the CCO system, and this is what I use in my daily routine, okay? But of course, and as I came today, is to talk about the transverse. And look at these images. Look at these images that I put in this slide. I don't know, guys, if you if you know this one. This is a frontal X-ray, okay? And I tell you this because we are very used to see this. And we are very used to see this, and in all of our studies, okay, when we are doing our studies for our patients, okay, before starting our treatments, we take a panoramic, which is very useful because we have an overall view of what is going on over here. And we take also a lateral ceph, which is sort of mandatory. And it's fantastic because here we can see 2 dimensions. But what about the 3rd dimension? And I'm not talking right now about CBCT. How many people take this X-ray? Because of course we also have parameters to see if the upper bone, the maxilla, is narrower than the lower, to see if the upper is coordinated in the lower with the lower. And the point of this is that the transverse has been forgotten. Pretty much nobody knows how to measure it. So you just see like a crossbite and you say, oh, the maxilla is narrow. Seriously? And how much narrow? This is what I'm asking you. You know that is narrow because the teeth are in a crossbite. But my question to you is, good, probably the maxilla is narrow. But how much? you put up an expander, and how many turns do you have to give? You remember that everybody gives turns and they have to overcorrect the vocal cusps. I remember the molars, when the lingual cusps of the upper molar touch the vocal cusps of the lower molars. You know what? It depends. It depends. Because if you are giving the turns in the expander to an 8-year-old, it's not the same expansion, the bone expansion that you are going to get than in a 12-year-old. So it depends. So what I always say is that if you want to see if the upper bone is narrow, you will have to measure in the bone. And you will have to measure at the X-ray, okay, over here. So let's talk a little bit. This is the issue, and this is the problem of forgetting the transverse dimension. Okay, so let's play a game. Let's play a game with you guys. Look to the photo, okay? I'm going to show you different photos, okay? And I want you to be able to tell me if the upper bone, the maxilla, is narrower than the mandible, okay? So look to the photo and tell me, is the maxilla narrow? Okay, so let's see over here. Check the photo. What do you think? Is it narrow? Yes, no, no worries, because we are going to see all these photos. And then I want to explain you like a small reference points, and we will see the photos again, okay? So my question to you is, and just think about it, check the picture, check the photo, and if this patient comes to your office, would you expand the maxilla? Yes, no. Look at this one. Is the maxilla narrow? Would you expand the maxilla? Would you like to be expanded? Maybe it's an adult, and then we will see how we do it. But would you expand it? Look this case over here. Look the mandible. Look the maxilla. Would you expand this case? Is it narrow, the maxilla? What about this one? Is it narrow, the maxilla? Maybe one side, maybe not the other side. We will talk about these things, because then when I go to meetings, when I go to congresses, then I always hear, no, let's expand from one side and not from the other side. Excuse me. I mean, if this is two bones, when you expand both bones. I mean, not one more than the other one. So we will talk also about this. But my question is, look at the photo, look at the picture. Is the upper jaw narrow? Let's check the next one. What about this one? What about this one? She has an anterior crossbite, but is the maxilla narrow? Would you expand this patient? What about this one? What about the upper jaw and the lower jaw, the maxilla with the mandible? Would you expand the upper maxilla? What about this one? Would you do an expansion of the upper or not? And this one? What do you think about this one? Let's see this other one. Maybe one tooth here in crossbite, the rest they are not, but check the mandible. Would you expand the upper bone? Would you expand the maxilla here? What about this one? Would you expand the upper jaw? What about this? I'm going to tell you woman because I treated her, but would you expand this woman? Would you like the maxilla to be expanded or not? And this one, this is my last picture. Will you expand this patient? Or the upper teeth have negative torque and you are able to bring them out? Okay, so let's talk. I'm sorry, this is the last one. Let's see about this one. Would you expand this one, or you see this one that is quite okay? Good. Now I'm going, before seeing and checking these pictures again, I'm going to talk to you about the reference points. When I talk about transverse, many people, they don't have a CBCT in their offices. Many people, they don't take a frontal X-ray. So Of course, today I'm going to show you how I measure in the CBCT. And of course, I do CBCTs of all my patients, okay? And I measure the transverse dimension in all my patients. But if you don't do it, at least I want you to have a reference and see at least if the maxilla is narrow when we are talking as a reference with the mandible. So if you need to see if there is a discrepancy between the upper and the lower, I want you to see and to have some reference point. So let's talk about this. First of all, the mandible, okay, it cannot be changed. Is genetically determined, okay? So of course, even if you want to do an orthodontic surgery, it's not very common like to open the mandible or things like that. So the mandible that you have in width, okay, is the width that you are pretty much going to have, okay? This cannot be modified with routine orthodontics, and it's not very common to be modified with surgery. So this is going to be actually the part that is not going to be able to be modified. So let's see where are we going to place our reference point in the mandible. And our reference point is going to be the mucogingival junction. Okay, this is where these two type of gingiva change. Okay, so this is going to be our reference point. Good. And it's very easy to determine. There is an article that it was telling us that actually the distance between the mucogingival line to the FA of the molar, of the six, of the first lower molars, is between 2 to 3 millimeters, okay? And this, it is very important because check this. Remember, guys, that the FA point is the center of the clinical crown, okay? So just imagine that when you are seeing the tooth here, you imagine the FA point and then the mucogingival junction. And this, for having the tooth in a correct position, okay, center in the occlusal plane, this measurement has to be between 2 and 3 millimeters. Okay, sounds good? There we go. So this is the point, FA point and mucogingival junction, and this distance has to be 2 to 3 millimeters. Good? So this would be an ideal situation. The tooth centered in the bone, okay, with the FA point and the mucogingival junction being with 2 to 3 millimeters of difference. And then we will love to have the upper tooth perfectly positioned with the lower. So this is the point. So look at this. Imagine that this tooth, the lower first molar, is with some with some lingual torque, okay? What happened? That between the FA point and this point, the mucogingival junction, is not going to be 2 to 3 millimeters. It's going to be more than 2 to 3 millimeters, okay? So then when you upright this molar, what is going to happen? That this tooth is going to be in a crossbite, okay? So then it will give you some idea if the upper jaw is going to be narrower than the lower. And this could be the other option, okay? So let's look to the photo again. Let's look to the photo again, okay? And tell me if the maxilla is narrow. Tell me if you would expand now, okay? Look here and allow me to put, because I draw the points. Look here, I put the FA point and the mucogingival junction. Look how tilted is this molar to the lingual. Is this molar correct in the bone? It's not. So from the FA point to the mucogingival, there is no 2 to 3 millimeters, it's more. So just imagine that when you have this molar corrected in the position with our orthodontic treatment, this maxilla is going to be even more in. okay? So this is telling us that there is a narrow maxilla. Let's keep going. Look this photo over here. Let's draw these reference points, the FA point, and look the mucogingival junction. So of course here you are seeing a crossbite. That's fine. I don't care. That's fine. But look how much do you have to expand. The point is, imagine this tooth that is torqued to the lingual. When you upright that molar and you put this reference 2 to 3 millimeters, that is the expansion that you have to do. So of course, in this photo, in this case, the maxilla is narrow. Let's check this case over here. Look, the same. Look here, the molar, how tilted in is. So when you upright, of course, this one in the side, in the third quadrant is going to be, you are going to see the crossbite even more intense, okay, and even more severe than in the other side, but in this side also. Remember that from the FA point to the mucogingival junction, it has to be 2 to 3 millimeters. When it's tilted in, when you have some lingual torque in this first, because it's compensated that the maxilla is in, then you are seeing this measurement more bigger than 2 to 3 millimeters, okay? Look at this one. Look this photo, no crossbite, no crossbite, okay? And check, look the difference here. When I place my brackets in the lower and upright the teeth, and I put my teeth inside the bone in a perfect position, what is going to happen? That the upper jaw is narrow. Is narrow, is going to be in a crossbite. Let's check this one. How is this case looking? Beautiful. Beautiful. From the mucogingival to the FA, 2 to 3. No need of expansion here. The maxilla is looking good. Let's check this one. That many people will say, oh, let's put here some aligners, or maybe a 2x4 with brackets here, and we organize the teeth a little bit. There is no crossbite. Oh, well, maybe here, but I can organize it. Well, check the landmarks, check the reference point. Look how this molar is tilted in. Imagine when we upright those molars. Careful, guys, careful. Of course, I take an x-ray and I measure always the transverse, and I'm going to show you how I do measure the transverse. But in case you don't have a CBCT, in case you don't do a frontal x-ray, check the frontal photo. Check the frontal photo. Check how are the molars, how is the FA with the mucogingival junction, if there are 2 to 3 millimeters, okay? And see how is the maxilla with that mandible, okay? That is very important. Check this case. Check this case. Also, here in this area, it might be better, but look here, more than 2 to 3 millimeters between the FA point to the mucogingival junction, okay? So sometimes we do need maxillary expansion, okay? So here, look, and again, I'm going to repeat the reference point. The reference point is mucogingival junction with the FA, and this has to be 2 to 3 millimeters. And then this molar has to be on top of it, okay? So many people, they ask me, so the lower mandible has to be the same size as the maxilla? And my answer is no. Actually, look here. This over here, if it was the same measurement, okay, what happened? That this molar would be end on, clink, 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 okay? What I need is this cuspid to be here and this one right here. I need an overjet. And this overjet measures 2.5 millimeters, okay? When I tell you that this means that measures 2.5, it means that it measures 2.5 each side. This means that 2.5 plus 2.5 is 5 millimeters. So the maxilla has to be 5 millimeters wider than the mandible. So this is very important because when I'm using an expander and I'm giving turns to the expander, we are going to see that now. We are going to see cases. And I give turns to the expander. It is very important that I give enough turns so my maxilla is at least 3 to 5 millimeters bigger, wider than the mandible. Okay? That is the plan. So look at this. How many times we see this? How many times? So what I want you is to see what is my goal as an orthodontist when I'm talking about transverse. And my goal is this. This is what we have in many cases, pushing the teeth out, bringing the lingual cusps down. But my goal is this. Look how the teeth are centered in the basal bone, the upper and the lower, and everything fits perfectly. So this is the idea. This is the idea of the transverse, from here to here. Check this case, a teenager, and look, here we see the discrepancy. Of course, you can do it without the expander and just push the limit, but the plan here is to put a rapid palatal expander, expand the case, and finish the case. But we needed to open the maxilla in this case, okay? There are some other cases, like this guy. Look here. And he's an adult. What is the only way like we are going to be able to fit this? And you know what? I'm tired to listen to people to tell me, oh, look at the negative torque of the upper molars. It's not about negative torque. It's about how much the maxilla measures and how much the mandible measures, and see if it's narrow and narrow. I mean, of course, I can tilt these premolars and these molars out, but I'm going to push the bone. So first things first, measure, and then do what you have to do. In this case, the only way to open the maxilla, it was with a SARP, a surgical assisted rapid palatal expansion. So in this case, we got him ready for the surgery, and we did an orthognathic surgery over here, a Le Fort, okay, and we opened the maxilla in this case. Look, now everything is in the correct torque, in the correct everything, but of course also the bone. So the bone now correlates with the lower with the lower bone, with the mandible, maxilla and mandible, and that is important. Okay, so from here to there, this is the guy there. And look at this woman. Look at this woman. Look at this photo. Of course, you can see here that the maxilla is narrow. Remember to check the reference. Look, remember how the maxilla is, okay? And you can see it already. And you know what? This woman told me, Julia, I don't want a surgery. I'm so scared. I'm so afraid. And I said, okay, no worry. It's fine. But I left her on a crossbite. What I do, and I have it very clear, is that I leave my teeth good and healthy inside the bone. And if they are biting the other way around, I don't care. I will do an occlusal adjustment at the end of the treatment, so she will be healthy for the rest of her life. This is my point. I mean, don't get crazy about putting the teeth out. You know what? There are times that it's impossible. If the upper jaw is narrower than the lower, you can push and push and push the limit. And then you can show me the photo and tell me, look how well you did it. I don't care, because actually you broke the cortical. And then this woman in 5-10 years, or maybe earlier, because she's already an adult, she will have problems with the bone and with the gum tissues. So let's be realistic, guys. Let's be realistic and let's help our patient instead of not helping them, okay? So in this case, what did I do? I put the brackets, I put the braces, and of course, from the premolar back, I left her on a crossbite, and that's it. And I don't care, and it's not an issue at all. So right now, what I wanted to tell you is how I do measure. And I take a CBCT like the one that you are seeing here in every single patient of mine, okay? So I'm able to measure everything. I'm able to measure the sagittal, forward, back. I can see if it's a class 2, a class 3, very good. If it's a skeletal open bite because the vertical is very down, a long face, short face, of course, fantastic. I can see that on my CBCT, but also I can measure the transverse. And now, guys, I'm going to give you the reference points that we use on our CBCTs, okay? So it's very easy, only 2 landmarks, only 2. Actually, I do the landmark here in this coronal view, and then I measure in the axial view. So look here, I always do MX, MX. MX stands for maxilla. Maxilla, actually, this point, this reference point is from Ricketts. So it's not new. This is from Ricketts and is actually when the maxilla with the zygomatic starts, okay? In this round area, is the most concave point. So from MX and MX, I just draw a line. And then I get this cut and I measure it at the point of the 6s. Okay, first molars. Good. Over there. Very good. And I measure. And in this case, the maxilla measures 60 millimeters. I do the same in the lower, but I do from AG, and I call it like that. And this area is also where is the cortical over here, which is the mucogingival junction over here, where is the furca, okay? And then I measure it here at the axial view, okay? Mucogingival junction. And here, the mandible from there to there, first molars. And in this case, the mandible measures 55 millimeters. So look at this, the maxilla measures 60 millimeters, the mandible measures 55 millimeters. Look how the teeth are in the bone. Perfect. The maxilla is measuring 5 millimeters more than the mandible. Look how they are fitting the cusps. Perfect. So this is how it works. So let's see some other cases so you guys can understand how this works, okay? That is the difference. 60 is the maxilla, mandible is 55, so the difference is the 5 millimeters. So then the teeth, everything fits together. Good. So we are going to talk about when to expand, and then I'm going to show you the different kind of expanders that I use also and that we have, okay? What is very important, guys, and everybody talks about if expanding at early stages, meaning 7, 8 years old, the answer is yes, because there is evidence about this. I mean, it's not from me or it's something that I feel, which I do feel also when I see my patients, but actually the earlier a patient is expanded, we need it, expansion is going to be more effective, expansion is going to be better tolerated, and expansion is going to be more stable, okay? So that is what we want. We want to open the maxilla when it's needed, okay? And open it so the maxilla is 5 millimeters bigger than the mandible. These are different kinds of expanders, okay? For example, I'm sure, guys, that you know this one, the Hyrax. There are others like the Has, which is like a Hyrax, but with some acrylic here. So it puts some pressure into the maxilla, also into the palate. This is the bonded RP, okay? The bonded rapid palatal expander. So it has acrylic all over the place. And this is a TADS expander. And I'm going to talk to you about this expander also today, okay? The banded and the Hyrax. Okay, so this is the bonded RP, so the same and the task supported RP. So let's talk a little bit about this one, okay? And actually, I'm using it a lot. Right now in the market, there are many, and they call them MARPs, okay? And actually, there are some that they hold the expander to the molars with bands. There are others that they are prefabricated in a lab. These ones, I do them in my office, and the cost of it is pretty much zero. Is the acrylic and this screw. I buy these screws in a lab that they sell me. I think there are 10 screws of these ones for 5 euros. So imagine how cheap they are, okay? So, I mean, this is very easy to fabricate, and I'm using it a lot, okay? Where to place the implants? Careful with that. Me, for example, you can do it yourself, and I sometimes do it, and you know what? There are many times that actually my brother does it for me, and it's fine. So I tell him where to place them, or he knows perfectly where to place them. There are sometimes more narrow maxillas that is more difficult. So pretty much wherever you can place them, just fit them in, okay? Before we used to use 2 mini screws, but I don't do this anymore because sometimes when you get loose one screw, then you have to start all over again. So that is why I put the 4 screws, okay? And this is how I fabricate it. I just take an alginate or take an impression, or you scan it and you print the model, whatever you want, and you paint it, okay? And then you start fabricating with acrylic. With it, I don't care, you can do it with this acrylic that is liquid and powder. You put it here, you reshape it, you do the 4 holes. Actually, the personnel in your office can fabricate it for you when they have less work or whatever. And then you just adjust it. Over here, you put some acrylic or some composite inside, and that would be it. Actually, you know what? Now I use the blue composite that you put on for the blue stops in the molars. That is how I use it. So I put the blue, and then I can see it very well to take it out. So that is also something that you can use for help. Okay, so there you go. And it's already placed. And that's it. Very simple, very simple. So from here, look at this. You have this case, and the good and the beautiful part is that you can start with all the brackets in your mouth and then be able to do expansions like this one. Look here, the maxilla measures 55. Look, the mandible measures 58, okay? So everything, the expansion that is needed is 58, 55 minus 58 minus 5, because remember that it has to be 5 millimeters wider. It has to be 8 millimeters. So this is the beginning. The maxilla is measuring 55 and the mandible is measuring 58. We do the expansion and now the maxilla is measuring 61. Okay, from here to here, 61. Of course, the mandible is the same. But look, right now, 61 minus 58, how much it is? 4. So at least now we know that we have done an expansion and that the maxilla maybe is not perfect 5 more millimeters, but it's 4 millimeters more. And to us, is enough. Look at this case, 55 millimeters, 61 millimeters. Look the change from this maxilla to this maxilla. So please, guys, please, people, stop the dental expansion when what is needed is a bone expansion. When what is needed, the maxilla is needed to be expanded, expand the bone, because it's good for everything. It's good for the breathing. It's good for the health of the teenager or of the kid. It's good for the position of the tongue. The tongue is going to position more forward, so then the airway is going to open and they are going to breathe better. So for everything, it's good when you coordinate the upper jaw with the lower jaw in a correct way. Okay? So please, look at this now. Look here. So look how many people, how many meetings, how many lectures I've heard that they use aligners here and that they do, and with some elastics, crossbite elastics. Remember, when you use a crossbite elastic, it's because the maxilla is narrow. If the maxilla is not narrow, you will never, never need a crossbite elastic. So careful, or at least understand what you are doing, okay? But in this case, many people will compensate with aligners, this teeth in, this teeth out, buccal torque, lingual torque. You know what? Expand, expand, help your patient. So from here, look, you do the expansion, and you know what? No problems in the teeth, the same thing. Now, if you want to put the aligner, put it. If you want to put your brackets, put them, whatever you want. So from here to there. Here, you place the screws, you open. And then you just remove them. Of course, always is a little bit ready, but this is going to be like for 3 days to 5 days, nothing crazy, okay? And there we are. There we are. So remember, guys, rapid palatal expansion, when we expand, this does not have to do anything with gaining arch perimeter. Many people say, no, you know what? I'm going to expand your son, or I'm going to expand your teenager because we are going to be able not to do extractions. And you know what? Guys, stop thinking about teeth when we are talking about bone. So when we talk about bone, let's measure bone and let's open the bone. And when we talk about teeth, then we will talk about teeth, okay? So let's show you guys some cases also. This is very interesting. Look at this case. These are two identical twins, okay? Two identical twins with a narrow maxilla. Look at this, which is a mirror image, okay? One has on the left side and the other one on the right side, they have the crossbite, okay? But both of the girls, they were 14 years old. And look at this, I'm going to show you both cases. In one girl, we placed one expander, one type of expander, and in the other girl, we placed another kind of expander. So let's see the difference over here. Let's see the difference over here. In the first one, I used the TATS expander, and in the other one, I used the bonded expander. So let's see how this works. This is the TATS expander. Look, in this one, we place the mini screws, we place here the, sorry, the appliance, the expander over here, and we open. And this is the bonded RP, okay? And we gave the same number of turns. Look what I want to tell you. I used here this expander, the bonded expander, because it has acrylic everywhere. From here, from the buccal to the inside. Actually, there is a meta-analysis that tells us, with evidence base, you know, that the meta-analysis in the pyramid of the evidence, the meta-analysis is the most evidence. Well, there is a meta-analysis that tells us that the bonded RPE, okay, this one, the TATS, I mean, didn't exist at that moment when the meta-analysis was done, but this kind of RPE gave the less tipping. This is why we decided to put the TATS, and in the other girl, we decided to use this kind of expander, okay? Same number of turns. So this is the pre, and this is the post expansion. Look here, you can see the acrylic. Look the expansion here, you can see how many turns we did. But let's measure. Let's measure in the bone. So this is the initial, one girl, 60 the maxilla over here. And in the other girl, 59.13, pretty much 60, okay? So look after the expansion. The one with the mini screws, with the TATS, 65, from 60 to 65. Look the one with the bonded RPE, from 60 to 61.36. But check this, which is even more important for me. Look the expansion. Here you can see the mini screw. From here that they were in a crossbite, look now. Same inclination. Please look this one. Look the tipping that we are giving. But check this, even better. Look at this. This is the one with the bonded RPE. So the teeth are tilted outside, and then when we put our brackets and we give the correct position, look here, and on. So after placing our appliance and we gave turns and we checked and we saw that the lingual cusp was touching the buccal cusp of the lower molars, you know what? I don't care about that. Measure. Okay? So here is this one. Look, both of them, they had agenesias of the laterals. Look, the one with the TATS RPE. Look, the overjet of everything. Look, the size of these fake laterals. Look here. And of course, we are pushing everything to the outside and we are using the crossbite elastic. Okay, so please measure. Okay, look the arch wire expansion. How many cases I've seen like that? How many cases I've seen people and speakers saying, look how beautiful. Well, show me this image. Look this, look this. And you know what? At the end, everybody, oh my God, it's not fitting very well. Let's put some elastics. Guys, we are doing a kind of orthodontics only with elastics. And you know what? And if the patient does not wear them, we are putting the fault on the patient. Guys, check this. Check this. Okay? So remember, when we give dental expansion and then we correct it, look what happens sometimes to the bone, that the cortical gets thin. So look from here, sometimes we cross the limit. We cross the limit. But you know what is the issue? That when they're teenagers, they have gum here, they have gingiva. So you think that your case is beautiful. You know what? Careful, because when they become 32, 33 years old, 45, no more gum and the teeth are out of the bone. So these are what we are using, why we are using the expansions with TATs. We are seeing that the expansion is pretty the same in the front than in the back. You see there, these are like results that we are taking. This is other cases of mine, of mines that we are doing like the same thing. Look, we put the 4 here and then we open, and you can see here that the maxilla is opening. Other girl, look this case. Nobody would have done in this case an expansion. But remember, put here the FA point, put here the other reference point. Remember this distance from the mucogingival to the FA? Imagine that I upright that tooth. This is going to be in a crossbite. So look what we did here. I put a TATS expander in this girl, but look how much I opened. Look here. From here to there. And you know what? And I'm helping her. I'm putting the teeth in the right situation, in the right position. Of course, then I put my brackets, but look the sides already. Look the overjet and the overbite everywhere. Another girl, this of course I used, well, actually I don't use a bonded RP, I use some these McNamara's, but the same. I do an expansion, boom, and the same thing, and I open. And look this girl, no crossbite, but look where is the FA point. Look where is the mucogingival. When I upright that molar, of course it will be in a crossbite. Of course the maxilla is narrow. Look at this guy. Same thing. And some people tell me, oh my God, what an expansion. What an expansion. Look at this. Look the teeth. Look here. And you know what? Many people will say, you give positive torque to here with the aligner, some crossbite elastics. It's not about that. It's about diagnosis. So check the mucogingival junction here. Check the FA. Look how tilted. Look this area.
Look inclined, look the FA. I mean, these molars are inside. When you put them out, you're going to have a complete crossbite because the upper jaw, the maxilla, is narrow. So look now, but please look here. You know what? I did the expansion, but here maybe needs a little bit more. Anyway, I mean, I already have this guy on braces and everything, and I hope next time I talk to you guys, I can show you this case finished. So, sorry, I have 3 questions. One moment, sorry, because I just saw this. At what age of patient? I'm going to read the questions. So, at what age of patient do you consider using a surgical assisted RMA? Do the answer depend on using conventional bonded expander versus that supported expander? What age patient do you consider? Basically, this is something that I have that I have it very protocolarized. Okay, so I'm going to answer to you. When they are in stage 1 mixed dentition, okay, I always use a McNamara or a bonded expander or a Hyrax, whatever you want to use, okay? Dental supported expander, okay? Then when they are teenagers, okay, I use always, when they have all permanent teeth, I use with TATS supported expander, always. Until what age? This is a fantastic question. Well, it depends. On girls, pretty much until they are 14, 15, 1.5 years after they've got the period. Then I don't try it, okay? And with boys, the one that I have with more age is with 17 years old. But I'm going to tell you the real truth. When I placed on a girl that was 15 years old and I placed on a boy, this boy that is 17, this TAT expander, they feel a lot of pain. And when I'm telling you that they feel a lot of pain, is that they feel a lot of pain under the eyes, in the nose. Careful, because many times we are forcing it, and we break some bones over there, okay, and some things, and it's not good. You know what? If you are not able to open the maxilla, leave it for the future for a SARP, for a surgical assisted with a surgery, and it's not a problem. Actually, now they do them in 20 minutes. I mean, the point is that we are not explaining them well. And if you don't want to do the surgery, if you don't want to put the TATS RPE, then leave the patient on a crossbite. And it is not a problem. And you know what? It's not your problem. It's the patient problem. Okay? So these are the age that I'm using it. I never use a TATS supported expander on an adult without a surgery. I don't know if you can see me, of a SARP, surgical assisted, okay? I mean, only orthodontically when they are teenagers. When they are adults, I mean, I don't care what people say, that they tell me that there are studies that they saw a patient with 35 years old, that the suture was not closed completely. You know what? Try it on yourself first, and then try it in this patient. I mean, this hurts. It's not a joke. It's not a joke. So let me answer to other questions, okay? Thank you for the presentation. Welcome. Thanks to you to be there, for being there. For the type of expansion with acrylic and TATS, since it is lately recommended to keep the expander for around 1 year, do you remove the acrylic part earlier because of the soft tissue? No, actually, no. Look at this. You know what they are saying? They are telling, I mean, right now, talking about this TATS expander is like very fancy. So pretty much everybody talks about this. We have been doing this TATS expander since 2008. We started doing them at University of Pennsylvania. That is why we have the pen analysis, okay? And we use this kind of expanders. The point of this is, you know what? Sometimes I use them and I remove them when they have like 6 and 8 months, and you can remove it pretty much. But sometimes I forgot about the expander in the palate. So I keep going with my case, and suddenly the patient tells me, when are you going to take out this thing? And maybe it's 1 year or 1.5 years. You know what I mean? I mean, seriously, you know what? It's not an issue with the gum. Of course, when you remove it, the gum is reddish, but in 5 days, 3 to 5 days, the palate is perfect. Never had problems with that. And I am telling you that I expand a lot. When I'm telling you is I expand a lot, because when you start measuring, you start realizing how many this maxilla discrepancy you have, or at least we have I have in my country. Okay. But no issue about the irritation, actually. Of course, 5 days, that is going to be a little bit uncomfortable, but it will be fine. And then another question is, hello, do you recommend CBCT for young children also, age 7, 8? My answer to this question is absolutely yes. Yes. And actually, I take 2 CBCTs. I take one before and I take another one after I do my expansion to measure. There is no problem. And that there is already evidence about that. I understand and I know, like, for example, in countries like UK, like in UK, there are some kind of, I don't know if there are laws or things like that, that they don't allow to take CBCTs on kids or whatever. But there is in Florida University, Dr. Palomo already brought out, I mean, he's an expert on all these X-rays and all this stuff. He's not only the one, they have like a, how do you call, like a study group, study group actually about this. And this radiation, when you put it low, they have these measurements that I can give them to you. I have the parameters in my office, but there is not an issue at all. Actually, they always compare it to that nobody have problem to take their kids to the ocean in summer for 1 week, and everybody cares about this when this is for diagnosis. Actually, no worries. There is no worries. Then I understand that maybe in your countries there are some inconvenience. I don't know about that, but if there is an issue or any seriously like a severe problem for your kids, no. Actually, the problem starts when the diagnosis is not correct. That is a bigger problem actually for these cases, but that is not an issue anymore. Actually, what they are telling they told this also in the last American Association of Orthodontics already. They said that there is evidence about this and it's not an issue. Good. So this, and I want to finish with this sort of images, okay? Just to finish them and just to make you guys understand that, look at this patient. This patient also came to our office to my brother to see if he had enough space for placing an implant in the canine, okay? Look this. He is a 22-year-old boy. Look the gum, nice. They are expanding for gaining more space. And the doctor was asking my brother, is there enough space or you need more space for the implant? Look the CBCT. But you know what, people? I mean, you know what, guys? I don't want to show you anymore this because we are so used to see this. I want you to show you this. Look at this photo. Look here, the fenestration. No cortical, people. No cortical. And this was our fault. This is the fault of the orthodontist, pushing the limit. And he was asking, do you need more space? More space from where? So now he's 22 years old. We already extracted the canine, the person extracted the canine because it was very transverse over here or whatever, and they were going to put an implant. And now it's not only that. The problem is not that now they have to do a bone graft. And you know what? I didn't know, but there are times that the bone graft does not work. So look at this guy, comes to you to solve a problem, and here is the problem now. So please, people, careful. careful. Careful with these things. Look at this other case. An adult patient, 38-year-old, came to my office. Of course, he had ortho. Look here. Look how the molars are tilted in. Look the recessions. Look the recessions. Pushing them out, pushing them out. How many cases do we see like this? After ortho, of course. Look here, another one. No worries, no worries. No, here you don't need extraction, you don't need a stripping, you don't need nothing. We will solve it for you. When they are teenagers, no problems with the gums, no problems. But when they are adults, and you know what? These people, they are on their 30s. And these people are going to live until they are 90. So how are their teeth going to look? Are we doing them a favor with our ortho treatments? So please, people, careful with this. This is a case of mine. I'm going to finish with this that I did probably like 10 years ago or something like that, or 12 years ago. Look this case. Look this case. Has a problem in the 3 dimensions: transverse, vertical, and sagittal. Class 3, open skeletal bite, and then of course, this transverse discrepancy. And you know what? The guy told me, the mother told me, we don't want the surgery, Julia, so do your best. And look at this. Look what I did. I put the brackets. I did lower extractions, lower premolars. And you know what? To push the limits is not about the aligners. It's not about which kind of system you are using. It's about how you are diagnosing. But look here, I took out the lower premolars to correct the class 3. Then look, of course, I used crossbite elastics here and there. I worked hard this case. I worked it very hard, very hard. Look at this. And I kept going like this. And look from here to there. And look the case. Look the case. Look the boy. Imagine how happy they are. And you know what, guys? I actually can show you this case in 2 ways. One way is telling you, look how good I am, how good I compensated this case, how good orthodontist I am. But you know what? Right now, today, if I would do this again, no, not at all. Not at all. Not at all. Look here, please. This is the day I removed the brackets. Look the recessions already. And I finished this guy 12 years ago and he never came back, thank God, because if I see him now, I'm sure he's terrible. Look the molars. Look here, the FA point with the mucogingival. Imagine if I put this molar upright. Of course, there is a discrepancy in the transverse. I mean, of course, I'm going to have issues here in the gum. I'm going to have, look, here you can already see there is no bone. Look here, the gum. And you know what? Then we always complain and we tell the patient, don't brush very hard, don't brush very hard. You know what? It's not about brushing hard. They are going to brush normal, but there is no bone, there is no protection, and they are going to break everything. So this is it. So thank you guys, everybody, to be there. And I just wanted to remind you that we are going to be in Salzburg. Actually, of course, the course is going to be in English, and we will talk about all this. We will talk about the CCO system. We will talk about transverse discrepancy. I will talk about interdisciplinary treatments, which I love. They are my favorite, actually, because I do them with my brother. So I will show that part too. Of course, the founder of the system will be there, and also some other colleagues. I hope to see you there, and thank you so much.
So thank you, Julia, for your fantastic presentation and impressing facts of the do's and don't do's of the transverse. Thank you very much.
Thank you.
For the Salzburg event, the GCO team will be very happy to welcome you in Mozart's town, not only for a weekend. As I know, I live very close to Salzburg, and it's a great location to spend time Please don't hesitate to contact us for any more information and questions, whatever you want to know. I think there is coming in another question.
There are two that I can answer right now.
Yeah.
One is thank you. Thank you for you to being there. And then there is another one from, we have seen this kind of adult patients without any previous ortho. Of course, of course, of course, of course. And actually, yeah. I mean, without and with. The problem is that if you see them without because they have these dimension problems and the occlusion is not good, and then these forces have broken the corticals, that's fine. But when you see these issues and these recessions and these perio problems, because you didn't, or the orthodontist didn't do the diagnosis correctly, there is where the problem is. Of course, there are people with recessions all over the mouth, absolutely, without having ortho. And there are people with no teeth, absolutely, absolutely. But what I wanted just to make a little bit this click in your head, guys, is just for us to think about it. If we are doing the best for our patients, not only now, for their futures. Thank you.
Yeah. Can you see there is one question? Thank you, by the way, for your interactivity and all the questions. There is one more question, Julia. Do you use MCE from Moon? Can you see the question?
No. I never tried it, actually. I never tried it. I know him very well, actually, and I know a guy that works with him very well, which is actually works in Madrid, and is a good friend of mine. But the MCE, at first, then they put it also attached in the molars, so it's with the tats, and also it has like a support in the molars, and I never used it. And actually, I never used it. Because mine is very cheap. it works well. And I started using it when I was at the University of Pennsylvania. We used it there and it gives good results. And that is why we are using this one. But of course, this other one, the MSE, I'm sure it works fantastically well. Also, there is another kind of MSE, which is called the power expander, that it's amazing. It's very, very good. Actually, the screw is beautiful. The only inconvenient is the time that takes you to be fabricated, and maybe a little bit the price, which actually I think is like 400 euros or something like that. So at the end, is something that you have to charge extra to the patient. Me, I charge extra the tats, but I include my appliance in the treatment. Then, of course, depending on your countries, guys, because I know that when you are in Germany, you charge because of changing the wires. I collaborate with a friend in Austria that I help her with some cases. And in Austria, it's also different because of the insurances. So then maybe you want to charge the expander, I mean, whatever. But the cost for you, actually, for you and for your office, the cost of my appliance is pretty much 3 euros.
Julia, we have another question.
Very good. Sorry. Thank you. What do you think for the upper dental expansion? About some doctors said that they modify bone with gingival buccal torque with aligners. Well, I know this. I mean, I know doctors that talk about this actually, and you know what, there are many people saying many things. It's not that I want to tell you I don't believe, I don't, you know what, I mean, actually, I would love to. Don't get me wrong. For me, it would be much easier to tell my patients, you know what, I place aligners, I move your teeth very slowly, but I can move them out, and I create bone. I would love to tell my patients this. For me, it would be much easier to sell my case. Much easier. But you know what, actually, in my patients, at least, I'm not seeing this. But it's not only in the transverse. Also, when you are proclining the lower incisors, guys, and you see it, when you start with your class 2 elastics for solving a class 2, and we all had these issues before, You think that you can solve it with a little bit of class 2 elastics, and suddenly you start with class 2, proclining, lower incisor, and you can see here that there is no bone, that you need to graft. And of course, the other doctor was telling me sometimes they don't have bone from the beginning. Well, yeah, but you have to diagnose it. Me right now with the CBCT, I'm doing first a bone graft, a connective tissue graft, and then I procline my teeth. And I explain it to my patients very clearly, and they do understand because I talk about health. I talk about health in the long period of time. You know what? For me, if they come after like 5, 10 years, 15 years, and I'm not even able to graft over here because the recession is huge, I don't know. I mean, with these people that they say that they are able to create bone, is not in my hands. My answer is not it does not happen in my hands. And I only do ortho in my life. I love it. I lecture, so I picture all my cases. I work with my brother, so we do perio and grafting. And as I'm telling you, we used to do some corticotomies before and things like that. And in my hands, I don't create bone.
Well, yeah, we have 2 more questions.
More?
Mhm.
Yeah. Can you please make a presentation about how you make your appliance for scratch? Yes. Actually, if you come to Salzburg, I will show you personally. Look at this, and it will be lovely to meet you, Alexandra. And there is another, how long do leave the appliance passive? I actually leave it, there was a magnificent question before. Actually, you need to leave it between, before they were saying like around 5 to 6 months. Now they are saying to leave it like around 10 to 12 months. You know what? If it's not an issue for the patient and it's not hurting and it's not like uncomfortable, leave it around 6 to 8 months. Even if you want for a year, that's fine. If it's very uncomfortable, because sometimes it's uncomfortable for the patients or the teenagers, they don't want to wear it or whatever, just, I mean, with 5, 6 months is enough. That is what was written. I mean, also it's true that this was written in classical articles. I mean, now it's showing that it's better if you leave it more. And it's true, because not everybody heal the bone the same way. So the longer you leave it, the better. Anything else?
I don't think so.
No, me neither. But thank you so much for
Perfect.
your questions. Actually, that was fantastic and very entertaining.
Yeah. Again, thanks for your interactivity, and especially thanks, Julia, for your great presentation. And as Julia said, a lot of and many questions will be answered in Salzburg. We will be happy to see you again. Webinar is a fantastic thing, but to be in person, to meet each other, we will be happy to welcome you. For more information on Salzburg and for more information for Dr. Liebe, one of the lecturer, and for Dr. Antonino Secchi, the founder of CCO, we are organizing and preparing actually 2 more webinars. Please let us know for any questions. Normally you get automatically the newsletters with all the informations in. Yeah. Now, wait. What? Another question, Julia.
Yeah.
When do you add corticotomies with expansion?
This is like another lecture for like a or like for a dinner. Yeah, like a dinner. But you know what? When I was at UPenn, this was between 2008 and 2011. This was the time of the Wilco brothers. I don't know if you know these guys. These were the fathers of the corticotomies. Okay, at that point. We were doing corticotomies at our postgraduate program at the university like crazy. like animals. I mean, of course, there is evidence that corticotomies short the time of, I mean, they move the teeth faster, okay? The point was how faster, and if we want that. I mean, actually, we were doing many corticotomies, and right now, I don't do that many. Actually, I do corticotomies when I need to bone graft only. For example, if I see in my CBCT that there are fenestrations, okay, of the teeth before I do my expansion or for my ortho treatment, or imagine the lower incisors, which actually more than with expansion, I think we all understand it better with the lower incisor. When we have to proclaim the lower incisor a lot, imagine in a case, no, and already has very thin symphysis, I open, I bone graft, and at the same time, we do some corticotomies to help with the acceleration and with the grafting. But we don't do corticotomies anymore for acceleration of the treatments. Not anymore. I think the surgery is too huge for shortening the treatment 3 months. But we do them a lot, and we still do them for when we are doing the bone grafting also. I don't know if I answered the question, but yeah, I mean, I don't do that many anymore.
So finally, I check again.
But also, if you come to Salzburg, we will talk about this.
Yeah.
Am I saying
We have
it all
time at the
right, the
barbecue.
Salzburg meeting?
We have also time at the barbecue.
Exactly. This is it. This is the place to talk about ortho.
Very close. Yeah.
Yes. Looking forward.
Yeah. So I think it's time for a break.
Very good.
So I hope GC Orthodontics team say again, thank you for being our guests and hope to see you soon. And so, yeah, have a great evening and see